Okay, we are going to start the CNSAC meeting today, April 7th, 2026. It is 1 o'clock. Item number 1.0, a call to order, roll call, establishment of quorum. And so Jessica Lightcap here.
Alyssa Brown here.
Carrie Krogan here.
Elizabeth, are you here?
She was, she's not on. And so, there she is. She's back on. So you can try that. And then just for future, if you call the names and they're able to respond, that seems to work. So hopefully when you call her, she will be able to respond now.
Okay, Elizabeth Scruth, are you here?
Oh, she's on mute.
I'm also
Lizzie.
not seeing her on camera. So if she doesn't make it on camera, we're not able to count her until she is on camera. So we'll have our board staff reach out again. We have a quorum with Alyssa, Jessica, and Carrie, so we can go ahead and move forward while we troubleshoot any issues.
Right.
Okay. So we have quorum established, and now we can open up for moving on to item number 2.0, general instructions for a format of a telehealth conference meeting.
Good afternoon. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature, now known as Slido. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. I will then call on the individual and send the request to unmute their microphone. The individual should be able to unmute and make their comments. I will then proceed to the next member of the public who has a comment. I will also query our on-site location for comments as well. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you'll be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Please remember, committee members cannot address any item not on the agenda, items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically.
Okay, moving on to item 3.0, public comments for items not on the agenda and items for future agendas. So we can move out to public comment.
Sorry. We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for a comment. Okay, I'm sorry. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for comments on the WebEx. BRN HQ, do we have any in-person representation?
Hi, Mark. We do not have any public members present here in Sacramento.
Thank you. Would you like me to close this window?
Yes, please.
Thank you.
Jessica, I'm going to pause really quick. Board moderator, is there a way that you can address the settings on the WebEx? We are not able to see. There we go. Everybody in participation. Thank you. That is very, very helpful. Appreciate that. Thank you so much.
Okay, moving on to item 4.0, review and vote on whether to approve previous meetings minutes. The last meeting was item number 4.1, August 27th, 2025. And we do a roll call vote to approve them, right?
I motion to approve if we need a motion.
I'll second.
Okay, I approve also. And Elizabeth, is she on yet? And Marilyn not here. Okay.
Right, so if they call for the vote.
Yes, let's call for the vote.
We're doing the vote. I think we still need on this agenda item to go to public comment.
Oh, right. Item number 4.1, August 27th, 2025 meeting minutes go out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Oh, hold on here. Lizzie Scruth is saying she's here. Hold on. So she must be signed on as another one. Okay, so she's there. Okay. Olena Svetlov would like to make a comment. 1 second, please. Olena, on your computer, if you have a bunch of windows open, it's a little box that opens up and it usually opens up behind everything. There you go. Perfect.
Thank you. This is Elena Svetlov. I'm a president of California Clinical Nurse Specialist, and it's an honor to be here today. And thank you so much for having this meeting. And I would like to support our clinical nurse specialist practice. And later on, we're going to have some comments on that. I would like to also to make some comments about our future practice. Thank you so much.
Thank you.
Thank you for your comment. Committee Chair Lightcap, there are no other public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes, please.
Thank you.
Okay, and now we can do a roll call vote. Elisa Brown,
Yes.
Carrie Krogan,
Yes, approve.
Elizabeth Scruth,
Yes.
okay, and Marilyn Bobbio is absent. Jessica Lightcap approve. Okay. Next item. Okay, item number 5.0, information and discussion only, report from the Board of Registered Nurses Executive Officer regarding updates on activities which may impact CNS practice.
Thank you for that. Really, there hasn't been a lot of movement around CNS practice. We do have our sunset bill that is currently moving through the process. We don't have language yet, but we did have our hearing on March 10th, where we discussed just kind of broad APRN topics, but nothing specific to CNSs, other than the one thing that we did request in our sunset is to require national certification for licensure. And that again is for all APRNs, so that does touch on CNSs. And then another section that is for all APRNs is an RN delegation through a ordering process, if that ordering process is within their scope of practice. And so right now, of course, CNSs do not have the ordering ability in your scope of practice in California. You do in other states, but in California, and so that doesn't affect you guys directly, but that is a greater APRN ask. And so those are the biggest updates, but everything else is kind of, I want to say the keyword quiet on our end at this particular moment. I know that the nurses here, I'll just have the hair stand up on the back of their neck when I use that word. They're like, no, not the keyword.
Yeah.
But right now, everything seems to be just status quo. And so if there's anything additional that pops up, I'll let you guys know. Thank you. And any questions or anything around our sunset, I'm here to answer any questions that you might have that I can answer in this kind of short, condensed time period.
Yeah, Loretta, it's Alyssa. Can you just tell us what the status is right now with that review? That
It is. We haven't even received language yet. And so we
Okay.
do expect that the bill will have some language attached to it by the end of this month. And then that's where we will start having a more robust discussion about it. I know that you guys don't meet again until the fall. So that will be kind of the signing stage. So all the back and forth will be done with that. So just feel free to log into our legislative board committees as well as our board meetings, where I'm sure that we will go ahead and have continued discussion as the language gets kind of worked out so that we can get a bill to be passed at the end of this year and continue to work as a board coming next year.
thank you.
You're welcome.
Okay. We can open up for public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing in the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Only Ms. Swetlop would like to make a comment. 1 second, please.
I should be better this time. Thank you. Well, this is Alina Svetlov. I'm president of California CNS. Well, first of all, thank you so much, Loretta. I attended BRN meeting, a couple of BRN meetings, and I was really touched with your story, how you advocated for nursing practice overall, and having your story, studying as a nurse, from 16 years old and having your journey. That really touched my heart because as a CNS, we raise new generation of APRNs on a daily basis, residents, doctors, and every nurse coming in the profession has a story. So that really resonates, and what each of and everyone has in their history, in their journey, how to serve patient and serve the community. So this is one of the best profession that I chose as an immigrant coming to United States. And, hearing your story kind of like goes really deep into my heart. This year, I got a huge honor. I did not expect, but the team of clinical nurse specialists reached out and see if I can support them and lead them this year while they're preparing for the best and robust clinical nurse specialists to represent. So maybe I'm not the best person to speak, but I got a very amazing people who were working with me, and we were looking at the Sunset Review bill, and which is great. We're going to be in alignment with APRNs. But the problem with national certification for us here in California is and actually national level, we don't have enough certifications for national certifications for clinical nurse specialists right now. A lot of were closed up. For example, I'm an adult gerontology nurse practitioner, and at the same time, I'm adult clinical nurse specialist in acute care. But because I completed training for adult, I don't have certification for adult. And me completing the training as a gerontology nurse practitioner does not allow me to sit for the board exam to be adult gerontology CNS in acute care setting. So I have to go back to school and present the certificate of additional training in order to sit for the board exam. I've been in clinical settings and practicing as a CNS for almost 12 years in critical care and representing in a seat day by day. So that was a concern from the California CNSs to see maybe there is an opportunity to have a language allow not just a CNS board exam, maybe there is some kind of opportunity that other certification would count and allow them to practice as a PRN. For example, we have wound ostomy clinical nurse specialist. So there's no board national exam as a CNS wound ostomy, but we do have a national exam that certifies you to be in the specialty of a wound ostomy. For example, for psychology clinical nurse specialists, we don't have exam right now. So wondering if the board would consider and see if maybe we can have some kind of other options that allow more CNSs to be certified and allow them to be in alignment with other APRNs. We did submit more detail. We submit the letter back in, I believe, in January 29th. So hopefully the team will review that. Thank you so much.
You're welcome. We do have the letter. We'll have more in-depth certification language discussion on agenda item 8.0 when we're going through kind of the regulatory updates. And so we'll be able to have a better discussion at that point if you just want to hold off your public comment until 8.0. And we'll be able to kind of work into that a little bit more. It is, of course, directly with our sunset bill, but I think it also more relates to the regulatory process that's coming up to have that discussion. And so if you're still going to be here for agenda item 8.0, that would be fantastic.
Are there any other
She says, thank you. I don't, she muted herself, but she said, thank you. And thank you so much for supporting us. And thank you. There are no other requests for comments on the WebEx. We have no in-person representation in BRN HQ. Would you like me to close this window?
Yes, thanks.
Thank you.
And this was information only, so we don't have to do a roll call vote, correct? Okay.
Correct. Yes.
Okay. Moving on to item number 6.0, discussion and possible action, report from the two CNSAC subcommittees, public engagement and website and regulations. I can share from a public engagement and website area. I didn't have anyone reach out to me on any questions from the public or public engagement, and there are no updates from the website since the past meeting.
And I will defer. Oh, sorry. I'll defer the question on regulations to agenda item 8.0.
Okay, very good. So we can move out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Com- Committee Chair Lightcap, there are no public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes, thanks.
Thank you.
Okay, and we do a vote on the last before closing it. Moving on, right? Okay, Alyssa Brown,
Yes.
and I can second.
Actually, there was not a motion. It was
Okay.
because we did not make a motion, it's just information only. We don't need to do any kind of a vote. We
Okay.
can treat it as
This is-
possible action. So it was just a discussion.
Okay, moving on to item 7.0, information and discussion only, data on final dispositions of disciplinary cases against CNSs.
That's me. I'm trying to pull up the information. I'm so sorry. Like my brain, I have about 50 tabs open. So I just have to get to the correct tab here. I apologize. Give me 1 second here. And then Carrie, just totally off the record, if you need to drop off, you can drop off at any point, and then we'll hold 8.0 until you're back on to present.
Thank you. Thank you so
Yep.
much.
I'm just going to get to the meeting materials section here. There we go. Okay, starting on page 22 of the meeting materials is our data and final dispositions of disciplinary cases for CNSs. You'll see that it tracks across the top starting at 2018 and then is current as of 2026 4/1, so just last week. And you can see that currently this year we've taken 0 action on any CNSs for any reason whatsoever. And across the bottom, you'll have the total. And then what we really wanted to point out on this one is that the active CNS licensees. So as you guys fluctuate in your licensing numbers, your guys is actually trending down versus trending up. And so that definitely is of concern. It also will then show that you have the percentage of CNS disciplined. And so you can even see that if there ever is a disciplinary action taken on a CNS, that it is still such a relatively low percentage that is really what speaks to it. So just quickly, on the types of discipline, those are fairly self-explanatory on the left, but I want to get down and kind of talk just to make sure that we understand on the violation type, because there is some abbreviations used that we may not understand. And so the first one across the top is practice. That is your scope of practice. And so any CNS that is doing something as around their scope of practice that either does it in a negligent way or has unprofessional conduct or something around that, you would see it as a practice violation. 801 practice is typically an insurance related issue, where you can see that those were reported. OSD is out of state discipline. And we do have the authority that if any RN, whether it's an APRN or not, receives discipline in another state, we have the ability to take discipline in our state as well, based on the discipline that was taken in the other state. That is a public protection process that we typically use, because what we don't want to see is that a nurse discipline in one state and then they kind of state hop to a state that they don't have discipline and then continue to practice in the manner that they practiced before. And so that is one of the reasons why we would do out of state discipline. And then Carrie, you had your hand raised. What's up?
Yeah, I just had a question on that. So is that the out of state discipline specific to like their nursing licenses, or is it something like if they've got a DUI out of state that would follow to, you know, or is it specific to?
If the board that they're licensed in that state takes action on the DUI, we can take action on it as well. So it's all based on the other board taking action. And so not all disciplinary processes are the same from state to state. I was just recently at a National Council of State Boards of Nursing meeting, and I learned that in the state of Montana, they do not take any the nursing board does not take any disciplinary action on a first-time DUI. They don't even look at it until it's the second time, right? So each state is different in the way that they manage that. So if you received a DUI first time in Montana, the board would not take discipline against it. Therefore, we would not even know that that occurred in Montana because we wouldn't get a disciplinary notice from Montana, if that makes sense. So we have to receive the disciplinary notice from the Board of Nursing, particular to the state that took that action. Once we receive that notice, we have the ability to take discipline based on their discipline, not based on the incident specifically. So hopefully that kind of explains that a little bit, but you can just see that there's in the last, 6-8 years, there's been 3 out-of-state disciplinary actions taken against CNS total. Convictions is kind of what you would think, just regular kind of criminal convictions. SUD is a substance use disorder issue, and then of course sexual misconduct. Other is kind of a catch-all for various things that doesn't necessarily fall into those specific areas. And so that is important to kind of just take note of. And down below that is, again, the active license certification by fiscal year on all APRNs, and you can see where the CNS falls in there. And how that works. Yes, Carrie.
Sorry.
And you don't have to raise your hand. You can just
start talking. I want to be polite. Has the board done any research as to why that might be? I mean, it looks like, you know, nurse midwives are staying relatively stable. CRNAs are upping. Nurse practitioners are upping a lot. Hasn't the board done any research as to why the CNS is dwindling? Could it possibly be anything to do with practice authority?
Yeah, so there's not specific research, but there's a lot of anecdotal kind of thought around that. And so if you watch kind of like the federal government and just kind of legislative kind of action, you can see that there's a big push right now for primary care providers. And so you will see a huge growth in nurse practitioners because of that big push of primary care providers. When you have a push like that and there's funds attached to it, especially if they're supporting growth in academic programs, you will see an increase in academic program offerings, which then increases the number of practitioners that are able to go through that pipeline, right? And so you do see that around primary care providers, which in our state, the advanced practice RN that is a primary care provider in our state would be the nurse practitioner. So we're going to see a growth in nurse practitioners because that's where the federal government puts that focus and the monetary support, and your academic institutions will follow. The nurse midwife, you're going to probably see some growth pretty soon because there's been some big legislative pushes for access to care for nurse midwifery care. And so when that push goes through, funding again follows, and then academic institutions will follow. Nurse anesthetist, they have a very strong kind of push for that because of their ability and willingness to work in the rural areas, in the underserved areas. And so there is an overall shortage of anesthesia providers, whether it be anesthetists or CRNAs. And so there's going to be a focus there, especially when you have the CRNA that is fairly willing to work in any location that is needed. And so that will just kind of have a steady growth. And the clinical nurse specialist is difficult, right? I mean, that's kind of the broader conversation. There is, you guys did have the national exam, you guys did have a push for your full practice, and then it kind of went at the wayside for many years. Less national exams, not a robust national organization. Your organization is coming back and making headway, but it was a very kind of tenuous time where there wasn't a lot of push at the national level. And truly, in the state to state issues, there is not a lot of consistent information going out on what a CNS does. And so we've had this conversation in our previous meetings when we kind of talk about kind of title protection, right? Where CNSs are seen primarily as an educator, a leader and an educator in your larger larger healthcare institutions, specifically ones that are going for magnet status, and utilize a CNS to meet some of that. However, because of the titling and kind of misinformation out there, you'll get people using the CNS title without the certification, without meeting the requirements, right? So we believe that people are still utilizing CNSs in the incorrect way because they're not getting licensed, right? So there's a lot of anecdotal things as to why we're seeing that decline, but I'm hoping that as your organization becomes more robust at the national level, that's where trends seem to come from. So as you kind of heard in that kind of conversation where NPs, like it came from the federal level, went to the state level, and then now we're seeing it down to the academic level. And that just continues to follow through. Now, just to let you guys know, Carrie obviously had to drop off. We do still have a quorum with the members here. So while Carrie takes a moment to handle an appointment that she could not interrupt, we are able to continue on with this process and this discussion. I will ask that once we finish the conversation around this and go public comment, that we do hold off moving to 8.0 until she returns. That has been her request, and we're willing to do that. So if we have to take a break, we will at that point. But any other questions around this, I'm happy to answer any questions. Yes, Lisa.
Okay, so this is related, but I know our state does not have mandated reporting, let's say, by directors of nursing.
Correct.
And some states do, and I remember the hearings about it, and you know, we experienced it in the VA, although it's a federal institution. But we had a person who was hopping from place to place, stealing drugs, doing all that, and no one had ever reported him. They just asked him to resign.
Yes, that happens.
So, yes. So is that? Do you know state? Nationwide? Does that exist in most states or not?
No, again, all of the nurse practice acts are different from state to state.
Yeah.
And so in our state, the Board of Vocational Nursing and Psychiatric Technicians actually have a mandated reporting law that employers must report to their board any disciplinary action taken upon their LVNs or their psychiatric technicians. We don't have that. However, I was in a meeting just recently and it blew my mind because I never thought about it this way. We don't have a mandated reporting for employers in our state for RNs. So they do not have to report that. However, what was brought to my attention was, as a nurse, you are a mandated reporter. And all of our nurses must report to a nurse. And so that is something I'm willing to explore. I haven't taken a deep dive into that or even broached that with legal counsel, but I was liking to kind of really understand that a bit more on whether or not our chief nursing officers, whether or not our unit managers, unit directors have a requirement to report based on their mandated reporting requirements. And so they may have that in a way. I'm not quite sure. I'd have to open up that penal code. I would have to kind of take a look in there. But I can tell you that there are some people that view that differently than we did.
Yeah.
And so based on that information, I think it does need, we do need to take a bigger look at that and see if there is any effect that maybe we were not aware of that falls within that mandating reporting. There might be certain instances that must be reported then, right? I think that opens up a broader discussion, but we don't have a specific bill that says, that mirrors the BVMPT bill that says you as an employer of RNs must report. And Alyssa, you're absolutely 100% correct when it comes down to that. Especially a trend that we do hear reports on is when you have an employee of a healthcare system, they tend to get reported more often than a traveler of a healthcare employee of a healthcare system, because they have an investment on the employee level, and it typically goes through like a disciplinary process, et cetera, maybe union involvement, et cetera, and that gets reported out. A traveler, you cancel a contract.
Yeah.
So there are many times it's reported to us that potentially things were not reported because they just canceled the traveler's contract versus going through a disciplinary process with that. So again, all of it hearsay, all of it just kind of anecdotal, nothing concrete, because we do not have a report on this. But that is some of the discussion that we are aware of around kind of disciplinary issues and how they are reported. But we do get many complaints. So if you did read our Sunset report, which again, I have no expectation for you to read it front to back, it's about 150 pages long. But there is a lot of statistics in there, and you could see that our complaints are numerous, but our disciplinary action is, I would like to think, minimal in compared to our complaints received. And so we are receiving an ample number of complaints. It's whether or not they rise to the level where disciplinary action is required, or we're able to get the evidence to support the disciplinary action as well. So that is a much broader discussion, but it does kind of open up kind of different avenues for exploration.
Thank you.
Thank you.
It was not an advanced practice nurse, just to let you know.
Can you
Good.
can you explain what falls in the other category? I just can't think of like things.
Yeah, I can't either, honestly. But
Okay.
it could be, and I have no idea specific on here, but we are also involved in child support reporting, right? So if they are not paying their child support, we can hold a license based on that, the professional license based on that. Maybe that would be kind of the other, right? But there are things that kind of do fall out of specific things like that that could fall into that area.
Okay. We
Any other
can.
discussion around this? Nope. Okay. So you're able to, again, don't need a vote. You can take it out to public comment. If we come back and Carrie's not back, then at that point, I would request to take a quick break.
Okay.
Maybe 10,
Okay.
15 minutes to allow her to return.
Great.
Okay.
Thank you.
All right. We got to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing in the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Lightcap, there are no public requests for oh, sorry, somebody snuck in there. Olena Svetlov would like to make a comment. 1 second, please.
Dear committee, it seems like I'm the only one from the public today, but would like to make a couple of comments. Number one, in terms of number of CNSs in California going down and license going down, that's directly exactly how Loretta said. It's definitely the industry push. We see the closures of our, schools that produce CNSs. We see UCLA recently just closed the program completely. We have only several schools here open in Southern California to support the practice, and a couple of schools in the Northern California. And it definitely related to the industry and understanding what we do. On a national level, there's a strong support of a clinical nurse practice, independent practice. From 2010, we have 28 states that have independent practice authority. I'm looking at the map right now. California on our coast is basically the only one state that does not have independent practice or full practice or prescriptive practice. However, Washington, Oregon, Nevada, Arizona, New Mexico, Alaska, Idaho, and others, they have independent practice where they can really prescribe, diagnose, work collaboratively, basically work exactly like in the federal facilities on the full spectrum of the education and licensure, which basically aligns with the Future of Nursing report that they call Leading Change, Advancing Health, where the Institute of Medicine recommended that nurses should be able to practice to the full extent for the education and skills. We are concerned as a California CNS that we don't have really that much of a support in the state of California to meet and practice the way how we can. In our daily practice as a acute CNS, I see patients, I'm a part of a team, and I'm leading the clinical practice for my nurses. I'm leading it for my physicians. I participate in many initiatives that I have, and I teach our doctors how to manage the care for the patient and contribute based on my training and expertise. My colleagues from the other state, intubate, putting the lines in together. And to be honest with you, I guess I represent the unique CNSs during COVID. Here in Los Angeles, I practice at Cedars-Sinai. We basically were able to practice in full extent. I personally saw and screened for COVID in all shelters of the city of Los Angeles. I led the team as a clinical nurse specialist with independent practice because Governor Newsom removed any barriers. So I was able to prescribe, I was able to diagnose and screen the patients and send them timely to emergency rooms. And we had the clinic, we had the where I had my resident writing prescriptions for me to make sure it's all done. And we're able to support the crisis during COVID fully. So with that, there's a big support from the National CNS organization. Every single state support our practice and moving us to the full practice authority. There are some opportunities for us as CNSs to work within our full scope of practice and work collaboratively with providers such as doctors and DOs as well. And the other comment is, if we have a magic wand, the reason how we can increase maybe or change the spectrum, how people look at us, to create a mandate. Currently in the state of California, we have a mandate to have a mandatory CNS for neonatal and pediatrics. That's a must. And then maybe that's why we don't see pandemics of readmission of pediatrics to neonatal coming in back to the hospitals. However, we have pandemics of veterans and being homeless outside of the hospitals, and we're having pandemic of heart failure patients coming all the way from the rural community and here in Los Angeles itself that I see on a daily basis. If we can have a change in the state of California and have a mandate for adult and geriatric patients, have a mandatory push to have a CNS in the unit, give us a couple of years, you will see there will be no pandemic with that. really appreciative for two large organizations here in the state of California supporting clinical nurse specialists with the full spectrum as much as they can. LA General just recently with Dr. Nancy Blake pushing in to change the changes and ensure there's a CNS on the unit, not just population-based, and a huge supporter. And I had an honor to practice at the Kaiser Permanente Los Angeles Medical Center, where the clinical nurse specialists are still needed. They're still leading a clinical leader and able to support the organization with the full practice, whatever is able to come and practice. So that would be my two comments. Thank you.
Thank you. I do appreciate it. I do want to make one just clarification. You had mentioned that in full practice states, CNS can do intubation as well as line placement. I want to make sure that it's very clear that CNSs as well as other RNs can do intubation and line placement currently in our current practice under standardized procedures within licensed healthcare facilities. So that is able to occur in California through the use of standardized procedures and is not a barrier to any RN, including your CNSs, to be able to perform those. That is not tied to full practice authority here in California. So again, just remembering from state to state, the Nurse Practice Act varies. And we are a state that has standardized procedures that allows for our RNs based on competence and other specific guidelines to practice in ways that people may think lead to full practice authority or are considered part of full practice authority in other states. So
yeah, thank you for this comment. That's definitely
just so you know that
industry.
those can still occur here without full practice authority, essentially. The full practice authority limitations for CNSs is that you guys don't, in statute, you don't have a technical scope of practice outlined. Your scope of practice still defers essentially to the RN scope of practice.
Yeah.
But the RN scope of practice, just to be completely full transparent here, the CRNA has an RN scope of practice.
Wow.
So that is something to be very much aware of when you guys are practicing and working around that. Okay, so there is things that can be done in California without that official designation of scope of practice. However, prescribing or furnishing is not something that CNSs have or CNSs have. Ordering is an issue that CNSs do not have the ability to do, but neither do CRNAs, right?
Yeah.
So those are things that would come with full practice authority, but I want to make sure that your practice can be as expansive as an RN can be with standardized procedures in other areas that are utilized. So always reach out to the board. We'll work with you if you have any specific questions. Our nursing education consultants are available as well to do scope of practice questions. That's on our website. You can contact them too. But just when the useful practice authority is used, I think it muddies it and is not as clear as it needs to be. So I want to make sure that if there are areas within your scope of practice that you believe cannot be done in California, please check with us to make sure whether or not that's part of something that you guys are not able to do or could do. And just to clarify that out. But yes, ordering and prescribing obviously you can't do, but there are so many things that a CNS can do based on their competence.
Appreciate you.
So
Thank you so much.
Just put that out there. Thank you. I do see that Carrie is back, so we can move on to agenda item 8.0 once public comment is closed. So that's great. And then I was noticed that it looks like somebody dropped off camera. Was it just Carrie? Was that the one that I was getting noticed of? But you're back on camera now, so you're good. So board moderators, is there any more public comment?
Well, we have no more requests on the WebEx, and there are no. Oh, hold on. Olena says thank you so much.
You're welcome. And then it looks like Elizabeth dropped off. Is
She
she
dropped
in
off,
the
but she's
attendees?
she's gone. Oh, there she's back again. Okay.
Okay.
Okay. Sorry, Committee Chair Lightcap, there are no other public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes, thanks.
Thank you.
Okay, moving on to item 8.0, discussion and possible action regarding the proposed draft regulatory language for clinical nurse specialists, including but not limited to definitions, application process, and education oversight.
Okay. So Carrie,
Yeah.
are you
I
ready?
I think I need to help with that one.
Melissa,
Yes.
ready? Um,
Sorry, I appreciate it. And thank you so much for letting me.
if you
jump off
need
with
a 10-minute break and you want to start
Let
at
us
2,
know.
we're definitely willing to do that, Carrie, if that's
Oh, no,
something
it's
that would
okay.
benefit.
Yeah, it's okay.
Okay.
Let's go ahead and
Okay.
muscle through. Thank you.
Okay.
Yes, so we are bringing back to the committee here, wanting to discuss the draft we had proposed in previous meetings. Since then, we've recognized, I think, that we need to make a discussion as an advisory committee of what we actually want to advise in our drafts, considering a couple of things. The sunset review, we know that the board is, working towards national certification, right? Currently in our drafts, we do not have that as a requirement for licensure. Wanting to stick with the APRN consensus model, right, which suggests national licensure. And I think also wanting to, I think it ties into, as we are working legislatively towards full practice authority to be able to bill, I believe we need to have national certification, right? While we don't want to leave anybody out, right? And we want to still make sure we have the pipeline running for CNSs. We also want to make sure we draft our language appropriately that I think will also be picked up by the board as well. Right. I don't know if it's important, I don't want to draft something that we put through just to get kicked back and we, because we're not in alignment. So we really kind of needed to bring it to the committee to decide if national certification is going to be a requirement, considering that we would definitely have like legacy grandfather clauses in there as well as to not permit anyone who's currently practicing, with their license to still be able to practice. And looking at what the oversight of educational programs would be. Do we want to have, as long as a educational program is accredited, right, that they kind of maintain that, and then the board looks at programs metrically as far as, graduation rates, pass rates, attrition rates, give the board that site. So we kind of just wanted to bring that here for robust discussion.
And just
Yeah, Alyssa, Loretta, please hop in.
no, just we did send out, the board did send out the draft for everyone to look at. So, we'll welcome comments today, but also if you have any others, to please send those in. We're also looking at the whole document in terms of definition, education, all those requirements. So yeah, please look at it.
Cool, thank you. And then just so you understand, this draft document truly means nothing authoritatively, right? So I just want to make sure that that's clear. This was a draft document that was presented to us by this committee a year ago, a little over a year ago. I think it was like fall of 2024. We had made 0 changes to it to date. We have attempted to make changes, but we get caught up in the ask. So a lot of these definitions that are on here, just even looking at the beginning, really tie to academic oversight, right? And academic oversight is absolutely necessary if we're licensing solely on completing a program. Right. And that's really where that question comes from. if we are licensing, and this is the pathway that this CNS advisory committee chooses to move forward with, right? We would put it forward as a recommendation to our board, but our board, as Carrie has said, as I've said, as public comment has talked about, our board at this point is supportive of national certification because they do want to align with the APR and consensus model that we took a vote on, I think in like 2010 or 2014, something, many, many years ago, we agreed to align, and we're working in that to align. Additionally, and I'll go through kind of like the pros and cons, but I want to just kind of set the stage here of why we would have to look at academic institutions differently if we're licensing basically on just completion of a program. So when you license on completion of a program, then you're licensing a person without any kind of metric or benchmark or a exam, essentially, right, that says you did obtain everything you were supposed to obtain in your academic program. And that really kind of to bring that back into context, when we look at it from a pre-licensure standpoint, we have programs that graduate multiple students, but their pass rate of the NCLEX is what really highlights whether or not that person has met the criteria for that entry level practice, right? Is everybody in the nation relies on the NCLEX to say you are safe to enter the profession of nursing. So you can graduate from a program, you can get multiple degrees, but unless you pass that NCLEX, you're not considered safe to practice or enter into practice, right? And that becomes kind of the bar that is set, and that is where it is pre-licensure. Additionally, that is your entry into employment, right? But what our boards use that metric as is when we're looking at the point of consumer protection. Consumer protection starts with our academic institutions. You have somebody that is entering this program and that is paying tuition, that is dedicating their time with a product that is promised to them. And that product is educational preparation for licensure and being able to safely practice. Well, without that metric of an exam or something that says that, we don't have a metric that we're able to regulate or look at to say, yeah, you guys are doing a great job. And I'm talking in broad terms, so I want to make sure that we obviously can look at other things, but that ends up being a very kind of easily identifiable metric that says, like in our pre-licensure programs, you drop down below 75%. So we look at that as a kind of a metric that has said many things have fallen apart before you hit the student, but now that NCLEX tells us that you've now affected the student, right? And that's the consumer, and that's where we come in. So the NCLEX pass rate doesn't necessarily say everything that's going on. What the NCLEX pass rate tells us is now you've affected our consumer, right? So we can look at graduation rates, we can look at attrition and retention, we can look at, we could reach out and get like employer information. We can pull disciplinary data based on where they went to school, right? Because we collected information where you went to school, and we can say, in this school, do their students show more disciplinary action than the other one, right? Like those are quality indicators that we could look at when we're looking at academic institutions. And so when you're licensing someone based on completing an academic program and not based on meeting an exam that has a national standard, that means we would have to look at these regulations, and we would have to be very detailed in how we watch those academic programs, because we don't have that metric that says now you affected the student, right? So that makes, as Carrie pointed out, that we have to have these robust regulations that you have in front of us, that we would have to continue to go down this pathway where we would require academic approval, where we would require this type of oversight of our academic institutions, and where we would do routine reviews of our academic institutions to ensure that they maintain compliance with our rules and regulations. And we would have to create a pathway for how they would have any kind of corrective action, right? So that is really where we would have to lie if we decided to not base it on a national exam. When you base it on I want to be licensed on national exam, that becomes like your NCLEX metric. We can watch that, right? So we start watching your graduation rates, we start watching your attrition retention, we start watching like just the output versus the in the weeds of the school, right? We wouldn't have to like critique curriculum and critique faculty and critique clinical placement and critique administration and who does all that, because now we defer to, if you guys chose to, we would defer to national accreditation or regional accreditation for the school. As long as they maintain accreditation, that's great. And as long as their national board pass rates stayed good, then we wouldn't have to look at that academic institution as detailed as it is in this regulatory proposed draft language, right? So that's where like in our meetings where we're like on and on and on, we're like, well, we really don't know where the committee wants to land. So that's where that comes into play. Absent that, and we look specifically at the national certification, a lot of the stuff that we really want to look at with that national certification is promotion of your profession. When you guys talk about a profession and you want to do title protection, you look at your licensing requirements. Right now, the established licensing requirements are is you complete a master's degree in nursing. That's our current statutory language, right? We obviously are in the regulations, we'll be addressing what we need to do with application and how that needs to be done, where you show, you know, the leadership and the education and all that kind of stuff that really does come from being prepared as a CNS. And so when you're looking at title protection, you want to look at what do you want a CNS to have in California? And do you want to protect the CNS in a way that says you have met these standards, which are different and outside the standards of maybe a nurse educator, right? If you want to make that clearly defined definition. When we looked at this historically, when a nurse practitioner with AB 890 wants to move towards a more independent practice, the first thing they must obtain is national certification. They weren't moving, legislatively was not moving to any independent practice until they obtained national certification. CRNAs don't have any practice in California unless they are nationally certified, right? So those are things that you definitely need to take into consideration, which is what our board did when we looked at this, and we were like, we need to go to national certification so that if there is a chance in the future for you guys to get that independent practice, that we have a benchmark that is equal to the other APRNs. So in order for the nurse practitioner to move to a 103, they must have a national certification. It can be a retired or legacy certification. It does not limit them. They can do that. And they can move to a 104, which is an independently practicing NP. And they can do it with their current certification as well as whether it's retired or legacy or newly obtained, right? So that has to happen. You have to have national cert. The other thing that was discussed is in order to bill, CMS requires national certification. That's outside of the BRN. So that is a requirement. Now, it is not across the board in all states, but most states require a national certification for licensure as well. And so when you look at somebody that is educated in California that may want to someday work in another state, you would want them to have that transferability. And that transferability means you have a national certification. Separate from that and moving back towards the academic institution, right? Federal regulations require any academic institution that's providing distance education to any state, any student in any state, that they meet their licensing requirements, right? So if you have a licensing requirement that is national certification, they must meet that. Right now, our academic institutions do not have to meet that requirement, specifically in California, because we do not have a national certification requirement in California. And so when you're looking at the rigor of an academic institution, when you're looking at how we review that, it sets that bar really low in California because we don't have that standard. And so that's something additionally to take into consideration. And so there are many things that kind of come out of this discussion. I'm not trying to pressure you. I just want to educate you guys as to why this is out there. We have CRNAs have full support of national certification. CANP, the nurse practitioners and the nurse midwives, have come out. Their organization has supported national certification on licensure. So of the organizations other than California CNS or National CNS, the other APRNs have all moved towards national certification. I know that you guys have a hindrance because you guys don't have the national certification organization examination creators out there, and that's where the problem lies. But when you look at that from a broader perspective, and you're looking at that from trying to get your independent practice, when you're trying to get to your full practice authority, when you do not meet the standards of the other APRNs, that is going to become a hindrance in the future if that hurdle is not addressed here. The BRN does not want to remove anybody from licensure that's already there. So in these discussions, we're always talking about grandfathering in. If they have a current retired legacy certification, that's done. You're going to be able to be licensed as long as you maintain that certification. And that's how it is today. I can tell you, out of state CNSs come in through national certification. That's their only pathway in. So it is truly only our in-state academically prepared CNSs that do not have to meet that criteria. And that too creates a two-tiered system and a double standard, right? So that is something for us to look at. Now, meeting with the academic institutions in state, they want to align with the APRN consensus model as well, mostly, right? And so there have been some academic institutions that want to offer additional pathways. Again, we hear that, like there's not a women's health CNS, population focus exam. So what the programs in state have done, and they've already made this change, is if they wanted to offer a women's health, they are now offering the adult GERE CNS pathway, and they're adding additional clinical hours specific to women's health that then allows the person to graduate with the adult GERE CNS and a women's health specialty designation. So it is not limiting our women's health specialty designation, but it is allowing that person that has a women's health specialty designation to now actually get the national certification as adult GERE and be able to have a more diverse ability to work within the nation, to bill with CMS, and truly answer some of the issues that have been described in California and nationally about the deficits in women's health care. They're able to look at perimenopause and menopause and really focus on that because they have the adult GERE aspect of it, and they're able to do gender studies because they know more about all of the genders that is included within the adult GERE and not just focused on a women's health area. So it has been received really well, surprisingly. I thought that we were going to have a bunch of pushback, and initially we did, but once they transitioned, it's been received really well. and it operates almost identically to the oncology CNS. I know that that's something that you guys are much more familiar with. There is not a population focus for an oncology CNS. And so when academic institutions offer an oncology CNS, they offer it as a dual degree. You get your AG, your adult geri CNS, and your oncology CNS. It goes hand in hand. And so that's what they're doing with any of these other specialties. So if you're looking for a family CNS, a women's CNS, an oncology CNS, all of those happen in addition to the adult geri as being the primary that gets your foot in the door. Now, of course, obviously, this is different than our psychiatric mental health CNS, and that's really the holdout, right? That is really where it is typically done in alignment with the adult geri CNS as well, and they're adding the psychiatric part of it. The pushback is from the providers that have that psychiatric CNS saying that you really don't need that adult geri. And you're correct. It's the same thing with the women's health. They really don't need that adult geri, but it has been beneficial to have that and then specialize out. So that is a path forward. That is something that our board has considered. We've worked with our academic institutions, kind of taking in that entire picture. We know it's not where you want to be. But the other thing that I learned very early on in my role as an executive officer is the California effect. I didn't know that this existed, but it makes sense now that I'm here. We are the largest state. We have the largest number of providers in our state, nursing based, right? We have over 500,000 nurses in our state. When you look at that from other states, we kind of are combined of like 17 states, truly, when you look at the numbers that come out of them. And when we look at it kind of statistically, we're about 13% of nurses are in California. When we make a change, the nation follows a lot of times. And so if we move to a requirement for population focused national certification, then there becomes a push for a population focused national certification, right? Because if we have the largest number here, well, then you end up pushing that need further. And if that need is kind of brought about by this, it may, I can't promise, but it may have an effect on the national exam providers to be like, hey, there's a supply and demand, right? So we have a demand for this, we need to supply for this. With California not having a demand for it, that becomes part of the problem too, right? Because we are the majority of licensees. And so I think we can potentially affect that as well. My last point that was kind of considered in this when the board kind of took this consideration as well is we know statistically that you're able to pass your national certification the closer you take it to licensure. And so by us not requiring it for licensure, people are able to put it off and put it off and put it off. And you may not ever obtain that national certification in the future. And that will be problematic if and when they want to obtain that. So if they wanted to move out of state to a state that required national certification, they worked in California and they never got one, they have a lesser chance of being able to pass that in that phase. Additionally, if we ever got full practice authority in California and were able to bill, you would now you would not have a lesser chance of passing that national certification. And therefore you wouldn't be able to bill. You would have to fall under another provider's, billing and defer to that, kind of in the same situation you're in right now. And so those are things that I always want you guys to have in the back of your mind when you're looking at this and trying to do title protection, making sure academic institutions are doing what they're supposed to do, making sure that you have the ability to move forward in your profession when those requirements become it. And then the APRN compact that is being floated around there and rewrited, if you ever wanted to be a part of that, it requires national certification. And so those are things when you're looking at telehealth, when you're looking at all the kinds of other things, you have to keep in the back of your mind, which is why our board decided to pursue this, seeing all of those positives and less of those negatives as to why our board does that. Now, again, you guys are an advisory committee. You can have a completely different standpoint. We would still put that forward into what your concerns are to our board if you guys made that motion. But where Carrie and Alyssa are sitting right now is we can't streamline these regs. They're in no place to move forward until you decide on national certification, because once you decide on national certification, we can decide on academic oversight, and then we're able to move forward with regulations on those. As it stands now, if you guys don't decide on national certification and you don't decide on the academic oversight, it basically means we will do a regulation on how to get an application through California. And that might be pretty much it. So that ends up being a little difficult and probably not what you wanted, but here for questions. Carrie and Alyssa are knee deep in this as well and are able to answer questions. And one of the things I shared with them yesterday was Alyssa has an opinion, Carrie has an opinion. They differ completely. And it's amazing because it allows for a really robust conversation. So I'm going to turn it over to you guys, and I'm going to hush up now for the next few minutes and allow you guys to discuss internally and share your thoughts on this.
I know. Thank you. Carrie, you want to go first, or you want me to?
I just wanted to thank Lori for all of the information, because that I think really gives us more informed information as a group, right, to kind of make these decisions. So I just wanted to thank you, Lori, for all of that.
Thank you. I agree.
Mhm.
And now I'll go back to my it's like the chicken and the egg, which came first. The fact that certification closed down, then schools closed down. And so my concern, let's say for psych mental health, which is what I am, and certification, I'm not sure it'll happen if it's just connected to another kind of program. And I feel like we're putting, round pegs in square slots, or vice versa, to make it happen. And let's say someone wants to be a psych clinical nurse specialist. They have to go to a GERI program. Being that my subspecialty is GERI, that doesn't bother me as much. But, I think Elena, one of our public, referred to how she has to go back to school to fit in. Whereas these other people don't. The other thing to keep in mind is that the NPs, the CRNAs, they have an organization that provides their certification. They don't have to worry about that. We have been fighting to get the credentialing center at ANA to reinstate. We have suggested they have an APRN certification, and then you could put /CNS or /NP. The roles are different, and we need both. But it seems to be just, focusing on keeping the NPs. When you look at the regulations, by the way, I mean, these are way too long. So, just keep that in mind. We cut off a lot of it. One of the things that I did send, to some of our people, Carrie and I discussed it, I sent it to the board, was some other states, and we have a few of them that have another option until we can get certification back, that allows CNSs with no available exam to have some sort of competency-based equivalency, where they might maintain their professional status, show that they've had a required number of clinical hours, have a portfolio option, but some way that they have to prove and attest to the fact that they are experts in their specialty. And that would allow for them to have that option if they can't get certification right now. With the idea that in the future there will be certification available to them. I know that also may be a lot more work for the board, to look at individual applications, but you already do that with some people. So, I've just been very vocal about that. I think basically, I think the credentialing centers, the administrators, the educators, and the practice people need to sit down and have a long talk, but they haven't done that. I'll stop here.
And I'm more on the school of train of thought of, looking at this national certification, right? Again, as I mentioned before, conforming to the APR and consensus model, making it easier for people to be able to actually move around nationally, right? Being able to bill when we get there and have independent practice, if that is our ultimate goal. Now, I don't want to disenfranchise anybody and have them not be able to continue to practice or, anything like that. But I also don't think we should make regulations conform to the few rather than the many, right? And so I'm more on the board of, I think we should require national certification with just a different oversight of the educational programs, as Lori was mentioning earlier, just for multiple reasons. And I think if the end goal for us is to have independent practice, I think that's what we need to do. And I think we need to align with the rest of the APRN groups. And hopefully, again, fingers crossed, right? To Lori's point too, like if we're such a large number, right, and we say no, we need national certification, now we can hopefully push those testing centers to create the tests, right, for psych, bring those certifications back for women's health, any of those varying ones. So there's our two sides of the the scale here,
We're still friends.
Yes.
We love you, Alyssa. One of
Can-
the things that I think is good to point out is you guys have two national certifying bodies, right? You have the American Association of Critical Care Nurses. They offer the acute care CNS adult geri, they offer the acute care CNS neonatal, and they offer the acute care CNS pediatric. That's fairly much in alignment with what they offer for nurse practitioners as well, which is probably why they're able to offer that in that way, right? They're able to kind of use a similar like exam and manage that. The other national organization is the American Nurses Credentialing Center. Again, they offer the CNS adult geri. They also offer the nurse practitioner, adult geri acute care, adult geri primary care, family across the lifespan, and psychiatric mental health across the lifespan, formerly known as the Family Psychiatric Mental Health, NP. So they did retire the exams on your peds, your geri, your adult health, your adult psych mental health, and your child adolescent psych mental health. So when you guys are doing as an organization, you're looking at an outreach, ANCC would probably be the one that you guys would want to approach to talk about reinstating an adult psychiatric mental health, because they are the ones that offer the NP, adult psychiatric mental health, right? No other ones do, but that's where that one lives. When you're looking at women's health, I think knowing which organizations offer a current women's health could be helpful. We have the American Midwifery Certification Board, AMCB, and they offer the Certified Nurse Midwife Women's Health Gender Specific National Certification. Just midwives. Is there any leeway as a national organization that you guys could gain by reaching out to the American Midwifery Certification Board and say, would you guys be willing to create an exam for women's health for a CNS, right? They already have the nuts and bolts of that exam. The other option is the National Certification Corporation, NCC. They have one, again, that probably better aligns with you guys, because they are the ones that offer the national certification for women's health gender specific for nurse practitioners. So by reaching out to them, the National Certification Corporation, NCC, they may be more willing to create an exam for CNSs because they already have the one for the nurse practitioner and you most closely align. So pediatrics you already have. So your Pediatric Nursing Certification Board, PNCB, that's a national organization. You could approach them as a backup if you wanted to, but you already have that one. So that one seems to be fairly secure with the American Association of Critical Care Nursing. If you're looking at having a family, because I know that that was kind of discussed, because you have an adult Jerry and you have a neonatal, how hard would it be to combine that, right? To get a family that is with your current certifying body as the American Association of Critical Care Nursing. They have that because they have the adult care gerontology and they have the neonatal and pediatric. So they could hybrid something together. But you also could reach out as an organization to the American Academy of Nurse Practitioners Certification Board, AANPCB, because they have a family nurse practitioner across the lifespan primary care designation. They also have your psychiatric mental health designation for your NPs. And those end up being the most easily maneuverable or manipulatable one that could be utilized for your CNS. And so when you're looking at this from a national organization or even from the California-based organization, don't limit yourself to the national exams hold providers that used to provide, right? Make sure to look at all the other national providers out there. There are 7. There are 7 across the nation that offer varying national certifying exams to all of our APRNs. One obviously is specific to nurse midwives. One is obviously specifically to CRNAs, but that still leaves you with 5 that are focused on NPs. 2 of those you guys already partner with that provide NPs. So there are 3 that do NP exams that don't do CNS exams that could potentially do CNS exams when you're focusing your outreach. So again, I think there's just a lot of education, a lot of movement that needs to happen around the CNS. I know that the VA has given full practice authority to all APRNs with the exception of CRNAs. And so I know that you have a federal backing. It's just whether or not you guys can get the individual states and meet the licensing requirements, all of them. And it does kind of come down to that national certification. So focusing kind of outreach and focus on there, if you can get that national certification, that leads you to the ability to bill. It leads you to potentially acceptance of a full practice authority in other states. And it leads you to the APRN compact because that is a requirement. So those are things, again, just to drop in there as kind of just a thought process there. So back to you guys.
Thank you. Appreciate that, Laura. I know the associations have reached out to some of them. There's a big money issue. And I know APNA, the American Psychiatric Nurses Association, looked into doing this, and they said it would be way too costly. This was years ago for some of those associations to do it themselves. But, maybe a good idea to look at some of the others. It's just that it's just frustrating. What can I say? But I think we have to have this discussion and talk about it and see, where we go. I would like to see another option until we can get that certification, and it's going to be a while. Even if we meet with all these other associations, they're not going to say yes tomorrow.
Correct. And currently the other option is with our schools where they're offering the adult Jerry as the primary, and then your secondary preparation is in your psych mental health, is in your women's health, is in your family. And that becomes your primary with your secondary and bridging the gap that way as well.
So as far as this discussion here, can I make like a motion to include national certification in our proposed language, reg language?
You are able to make whatever motion you want to make. And if you don't get a second, your motion dies. If you get a second, your motion carries. And then we go out to public comment, we come back and we do a vote. And if you don't get a majority vote, your motion dies. And another motion can be made. So Making your motion doesn't mean it moves it. It just means it opens up for further discussion. And then again, based on your motion, if it's something that needed to go to our board, if it went to our board as an advisory committee, our board still has the ability not to accept it. They consider it, but they're not required to accept it.
Well, I would like to make a motion that we add national certification as a requirement for CNS licensure in our regulation verbiage.
Can I ask 2 questions? Am I allowed to ask 2 questions?
No. That's all. No,
No, not at all. I've already talked so much for everybody else. You don't get to. No,
Yeah.
absolutely.
I was just wondering if we have current statistics on like our current CNS licensees, like how many came through national certification and how many are coming through not nationally certified. That's my first question. And my second question is, for nurse practitioners or the midwives, or CRNAs, when they are being grandfathered in, but then they have to bill, they have to go back and take national certification. Is that correct?
Multiple questions. I'm going to try my best to do it. When they're grandfathered in without a national certification, they are not able to bill. That's hands down because CMS requires national certification in order to bill. So, yes, they would have to have a national certification. If they do not have it, they would not be able to do it. And end of discussion there. So that has nothing to do with us. That has everything to do with that process. I lost my train of thought. Can you remind me what the other ones were?
It was just about statistics on our current licensees, if they're grandfathered in mostly or nationally certified now.
Yeah, what route they took, yeah.
Yeah, because our board doesn't require national certification, we don't collect that data. We have no, but what I can tell you is every CNS that came from out of state had a national certification to come into California, because that is how our licensing team has required and processed, right? Our in-state CNSs, it's been a mix, right? So when I first became an EO here, there were CNS programs that were reviewed by our board that were able to sit for licensure. There were CNS programs that were not reviewed by our board because it was not a requirement. Who they graduated, they had to have a national certification because it comes on board review, and CNS programs, some chose to review and some chose to not review. So there are more CNSs with national certification than there are without national certification, but I don't have specific details. This conversation actually came up within our nurse midwife board advisory committee. And the nurse midwife advisory committee, they were worried about moving forward requiring a national certification because they were like, how many are we going to exclude? What's going on? And they pulled from their organization, they pulled the numbers. And it came down to, they have like 1,500, and I'm not going to have the numbers off the top of my head, but they have like 1,500 licensees, and maybe less than 10 when they pulled the data did not have the national certification. So there was a lot of what will happen and what ifs based on literally less than 10, not 10,000, but less than 10 people in the entire state of California not having a national certification. So if you guys are able to collect this data from your organization, that would truly be a benefit for you guys statistically to understand. But I can tell you that the majority, because when we look at license numbers, we have out-of-state licensee and some of our in-state academic institutions were not approved. They all required national certification by our licensing team to be licensed. Nobody has come through the equivalency method in years. I pulled that data one point, probably 5 years ago, and CNS equivalency had not been approved for probably 10 years prior to me pulling the data 5 years ago. So probably 15 years since an equivalency was done. So if you're not coming from a board approved academic institution in our state, you are required to have national certification. So even though no statistics, I can tell you that it leans towards the national certification. Because again, those academic institutions are required to have a program that prepares their students for licensure. If their program is educating anybody else in a different state, they have to prepare them for licensure, which means they prepare for national cert. Because our state is one of the few states that do not require a national certification.
Yeah, I took mine.
Was that helpful,
program.
Jessica? And then Carrie, yes.
Yeah, I took my program out of state and I'm nationally certified.
And it's a really good question though. Would be good to know that number, and maybe we can poll our members, I mean, and try and find out through them. But I kind of urge us not to make this decision right now.
Well, I have a motion out.
I know, but so it's open for
Someone
discussion.
second.
If it hasn't been seconded, I don't know who's going to second.
I would second it. I think we need national certification. We carry on this.
Okay, now we can have more discussion.
We can always have more discussion. We have a vote for a first and a second. We can have more committee discussion. We can go out to public comment. You can come back and have more discussion. Because if you do a roll call vote and you don't get a majority, this motion dies and you guys can do another motion, right? But right now you have a motion and a second, able to have ample discussion because we haven't done a vote yet.
Right.
I when I was asking my question about the statistics on the current licensees, I would also think that like maybe not the majority went through national certification now, just because it costs a lot of money to get nationally certified. And if you don't have to in the state of California, then maybe they are saving, $400 or however much it costs. That's my other thought with that too.
I just think we're going to, I'm just concerned about disenfranchising people in CNSs in California. I don't think it's going to strengthen our ability to move forward. I think it may hurt it. And I would love that. I'd love to, let's see what happens with your motion. I would put forth a motion to continue to consider an option while we're working on the regs.
Lizzie, can you share some of your thoughts too?
Yes, I do have to say that I was chair of the AACN certification board for 2 years. I just want to put that out there because it may, influence my opinions. I want to be very transparent. But when the regulatory in 2008, when the whole consensus model came about, there were some, and I understand what Elise is saying too. I appreciate that. There were some CNSs that were disenfranchised because they didn't have the required number of hours to be registered as a CNS. So that happened then too, but they still passed the consensus model because it's the right thing to do. Now that was in 2008, and here we are in 2026. And our counterparts, nurse practitioners, who sometimes people think more highly of nurse practitioners than CNSs, and we're a much smaller group, have been nationally certified for many, many years. And I do think we need to bring ourselves up to it as well, to be nationally certified and be recognized, be able to bill, get reimbursement from CMS, and to be recognized for our certification by the public as well, because they recognize nurse practitioners and their certification. I just think it's time. I think we've been lagging behind in this, And I personally think that it's way over time. We do need to get national certification. Thanks.
I appreciate that, but I will make one comment about the consensus model and remind people that when it first came out, they didn't even address CNSs in there. That any CNS had to write letters and petition and stuff and say, hey, you left out the CNSs. So that's how I feel about the consensus model. That's just my personal thought. And I appreciate what you said, Liz. I still think we need to give it a little more time. I would like us to consider it as we're revising these regulations for finality, and let us poll our, at least poll our members, CACNS.
And I
I think one
respect your opinion too, Elisa. Thank you. I respect it.
One of the things I do want to point out is your vote today, and this is going to sound harsh, but I don't know how much more I can be blunt with this, does not change our process at all. So not requiring certification for licensure continues to be the process in California until law is changed. That law change comes from accepted regulation or legislative update.
Got it.
So your vote today does nothing to the status quo until law is changed.
Mhm.
So if this committee says, I vote for national certification on licensure, fantastic. We're still licensing, not requiring a national certification. We draft language. This language comes back in the fall and it comes to the committee and you guys accept the language. It then goes to the practice committee of our board. It goes to our board. And then my board staff work on a regulatory package, which typically takes a year or two to get through the process. So nothing will change until that regulatory package changes it, which could be 2 to 3 years from now. So in these coming 2 to 3 years, you're still able to be licensed in California without the requirement of national certification based on these regulations. If they were to go forward today to say, I think we need to require national certification. So there is a 2 to 3 year period for you guys to get your data, to get that in order. And then we go to the comment periods. If we go out to a 45-day comment period when we send this to OAL and CACNS or NACNS says, we pulled the data, there are 3,000 CNSs and 2,800 of those CNSs do not have national certification. This is going to be horrible. You guys make that comment. We are required as a board to address those comments and change language. So if it was ever shown and our board agreed to it, we would revert language back to allowing for that to happen. So again, your discussion today is recommendations, is working towards something. It does not change the law that we have today, which does not require national certification. It moves us towards the future. We're looking at 2 to 3 years when we look at regulation. Absent that, if the sunset bill is written and requires national certification, which is what our ask is, and that goes into place in signed into law in the fall, and then is implemented in January, right? We still have to do regs. We still have that process. We will still have to address what we're supposed to do with here. We could ask for delayed implementation. We can do whatever. We could say moving forward. There are language provisions that can be done to address those concerns. We can ask for a call out for CNSs. There's many, many things that we can do. But your vote today, just to be very, very clear to the 38 people that are on this call, if that messaging goes back, is that you're still able to be licensed without national certification today. This just tells us where your profession wants to go in the future. And that's what's helpful for us.
Okay.
Lori, this is Reza. Sorry for the interruption. If I could just add one additional thing to it, to what Lori was saying, and this is kind of a separate issue. And I'm sorry for kind of throwing this in now and adding on to what Lori was saying, but as a totally separate issue. So under the open meeting, and this is kind of just strictly procedural, under the Open Meeting Act, we're required to notify the public on our agenda of what topics we're discussing. On this item, we've identified it as generally talking about the regs, including but not limited to definitions, application process, and education oversight. Now, that does kind of leave some open-endedness to it, but and I should say, by the way, taking a step back, I'm kind of throwing this out there for maybe Lori and our committee chair to kind of weigh in, because it's a bit kind of gray as far as the law on it. But the point I'm trying to get at is that the requirement of national certification for CNS certification is a pretty kind of major substantive change where, you know, so my kind of angle on it, my question is just, have we notified the folks out there that we might be talking about including national certification as a requirement? So far, we let the public know that we'd be talking about these proposed draft regulations, which didn't include anything about the national certification piece, and given a few examples, but you know, so on the one hand, you could say that, well, our agenda item was pretty open-ended, so it should allow for the inclusion of this. On the other hand, you know, you could say, well, that was a pretty big, significant piece that was kind of added in and not really necessarily contemplated by us or the public who might have seen our agenda. So all of that is just to say, an alternative that, you know, if we were to be very conservative from that standpoint, would be to put that specifically on a future agenda.
Tell me if I'm wrong, Lori, but we've kind of been discussing this since we started this advisory committee, right? We're on year 3 and this has been discussion. You're muted.
Unmute, Lori.
Somebody actually asked me to unmute. That's surprising. I'm joking. Usually it's the other way around. So this has been the general discussion around these regs just going forward. That's kind of where we've landed, which again is why we brought it back forward, which is why in public comment, from the beginning, they were very much aware and talking about national cert. And so national cert came forward in our meeting minutes. National cert came forward in the report out committees and discipline and national cert. So we believe that the public is aware that this was going to be discussed, because this has been the hang up as part of this regulatory package for 2-3 years now, where we're at an impasse where we can't move forward until that national cert is required, because then we can draft the regs around application and draft the regs around education based on this one determining factor. So with that, I think there was ample notice, but just to clarify, when we come back in the fall with regulatory language, we're going to have another discussion around this, right? Because it's not going to move forward until you guys accept it to go to the board. And so there's going to be another opportunity to discuss the regulations, and we could highlight in that specifically around national certification, education, all that kind of stuff if we need to. So this isn't the only time it's going to be in front of the public, even though we truly do believe that our public is very informed of why this is being brought back forth and contemplated and discussed. Additionally, when it goes to the practice committee, we can highlight it as well. When it goes to the board, we can highlight it as well. And when it goes out to 45-day commenting period for OAL, we can again highlight anything that you guys want to around this. So this is not our only time that we're going to be actually talking about this. It's going to come forward multiple times. And I can tell you that even at the legislative staffer levels with our sunset process, there has been a lot of reach out on the CNS side on the national certification. So it is the hot topic right now, specifically because we stirred the pot with the sunset bill request, but also because we do need to have this kind of broader discussion. So I think we're okay, Reza, if you're okay with it, that we can just kind of continue on this process. And we have a motion and a second. We're still having discussion. I do want to be mindful of our time frame. I believe we have about 12 more minutes. And so we might want to go to public comment and see where we're at. And I could be wrong on that minute time frame. We might have extended it. I'm not quite sure, but I think we were scheduled to stop at 3, but let me just check. It might be 3:30.
Can I just ask what the motion is again, the language?
The motion is to add a national certification into the regulatory verbiage.
For application for requirement, which then would affect the academic oversight, where you guys would have a different direction on what you would write for your regulations on that.
Okay, can I ask Reza a question, please? Is there a way to reword that so that what we're doing is putting in national certification as we work on the language to show what it would look like? Something, so it's not, these few people decided we will all have national certification, but something to the effect that, that we will include in the language, the regulatory language, what national certification will look like, as opposed to what we already have, something like that.
So again, just before Reza jumps in, I just want to be very, very clear.
Yeah.
If this committee says they want, like the motion stands, that they want to have national certification as required for application, it is not changing our current practice. So if you have 3 members of this committee that says, yes, move forward with this, because that's our majority, it is not changing CNS licensure requirements at all. It is truly where we're drafting language and bringing the language back to this committee in the fall for discussion and consideration. So please, 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 Alyssa, I think we're at where you want to be right now. This is just direction that you guys want to move forward in that regulatory language and present the regulatory language, what it would look like if we required national cert. So I think you're getting what you want by the motion that stands on the table right now, because it is not moving anything forward to our board. It is not even anything for our board to consider at all on national cert.
And I do want to mention, Alyssa, that even if we make this motion and this recommendation, it's not us in this committee who are saying this is what CNSs now have to apply, right? This is just, to Lori's point, drafting that, right? And if we decide on that, then it goes to the board and they could shoot it down or they could accept it, right?
I
Or just
understand all that. I'm just, in terms of how it looks in motion form, I think, what you said actually was, let's see how it looks in the regulations. Sits better with me than, we all decided this is how it will be. Even though I know what the process is, I know how long it will take. I look at language.
I think we should go out to public comment.
Yes.
And it would, just so you guys are clear with this process, it would require that Carrie and Lizzie would say they wanted to alter their motion in order for them to want to do that. So that has not occurred yet. So I think going out to public comment would be appropriate at this point, Carrie. Or Jessica, sorry.
Okay.
I was just going to say real quickly, I agree with everything so far. I think what Lori explained is kind of, it is correct that the motion, the way it is right now, does result in this coming back to this committee. There's no kind of final direction being taken right now. If to Alyssa's point, if the motion makers wanted to tweak the language, that's fine. I would just suggest doing that before public comment, if at all. But if those who made the motion, it's ultimately in your hands if you're comfortable and content with it and want to move it forwards. leave it as is and we can go to public.
I would like to keep the motion as is.
So would I.
Okay, we will move out to public comment then. Thank you.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing in the question box, "I would like to make a comment." I'll pause for a moment for members of the public to type in, "I would like to make a comment." Alina Swetlove would like to make a comment. 1 second, please.
I guess I passed my certification exam, how to unmute myself. So thank you so much. It's really a great discussion. Thank you for allowing us to be there. Definitely, if I would knew that that's going to be a motion today, I would make sure more CNSs are here and representing. It's not just me. Loretta, with all my respect, thank you for explaining. That's really, really helpful. You know, seriously, like very, very helpful. And, you know, the major question you said very loud and clear, like, what do you want to do as a future advanced practice nurse? What do you want to do? So 100% on behalf of California Association of Clinical Nurse Specialists, I'll tell you, yes, for the future, we'd like to be in alignment with all APRNs. Absolutely. We would like to get a national certification. This is absolutely correct. However, in the current state, and this, I'm not talking about like 3-4 years, in the current state, for example, right now I practice in an institution, I have 26 CNSs in just one institution. More than 50% do not have national certification. So I understand legislature is not there, law is not there, but HR is watching the language. The moment the job description will change and it will say, okay, now we require national certification, I'll be out of a job, number one, right away. Because I have national certification as a critical care nurse through AACN, because my my exam adult clinical nurse specialist expired. I cannot practice. I would not be able to practice and lead one of the academic institutions here. And I'm speaking to majority of CNSs that currently are preceptors for the new force of the CNSs. We are mentors for a lot of new CNSs who are student CNSs who would like actually to explore the CNS role, would like to go. What we're asking is, we actually, Carrie, to your point, we asked to tweak the language. We put it in our letter that we're asking, we're going to be in alignment, we are in alignment, and I would like to have this grandfathering provision for currently practicing clinical nurse specialists in California who have traditionally practiced under state authorized board recognition without national certification. If you just tweak the language and be inclusive of those who don't have certification per se as a CNS, because we don't have those exams to verify us to it, but we have other national certification with that, that would be perhaps enough. We are really, if we just say only with these 4 words, require national certification, mandatory, something like that, that would risk an unnecessary contraction of highly skilled advanced practice workforce that we have right now. And it's to Loretta's point, we have almost 3,000 CNSs there. We have a lot of people who would like to continue. We're moving to our prescriptive authority. Loretta, we're probably going to be reaching out on a separate level to meet and discuss with the national to see if we're in alignment, to make sure we support the public, and really asking the team and this committee to take a look and see if we can tweak that language. But for the future, yes, especially if you have academics oversight, making sure they have enough hours to practice, that would be really, really great. For the future is really great. But if we will just leave it there, then we're not going to have enough preceptors to support that future. So thank you.
Thank you. So I'm happy to kind of jump in on that conversation too. We have current language in our statute that when this happened in nurse practitioners. So prior to 2008, our nurse practitioners were not required to have a master's degree in nurse practitioner. And so when it became law The way that it was drafted in 2835.5 of the Business Profession Code said on and after January 1, 2008, an application for initial qualification or certification as a nurse practitioner under this article who has not been qualified or certified as a nurse practitioner in California or any other state shall meet the following requirements. And B is possess a master's degree in nursing, a master's degree in clinical field related to nursing, or a graduate degree in nursing. And C, satisfactorily complete a nurse practitioner program approved by the board. So as you can tell in that language that was for our nurse practitioners, when a large change happened to their licensing, it covered all of the grandfathering provisions. So if you did not have a master's degree in as a nurse practitioner or complete a master's degree and you had previously been licensed in California or any other state, doing that, you're able to maintain that. It is just moving forward. So Alina, your practice would not be altered. Alyssa, your practice would not be altered. Any CNS that does not have a certification that is already licensed here or any other state would still be able to practice the way that they've been able to practice in California. Now, to address the employer, we cannot require an employer to require certification or not to require certification. And that is a much larger conversation, because when that employer goes for magnet status, they are required to have a CNS. So magnet status is much more important than not having a CNS because they don't have a national certification. So you have a battleground already set for you that is in favor of you guys maintaining your position regardless of a national certification. They need that title of CNS. They need that person in order to qualify for them to obtain magnet status or continue magnet status. Magnet status does not say you must hold a national certification as a CNS. It says you must have a CNS on each one of your floors providing services. So although I hear that that's a fear and potentially could occur, there is also, again, the fight, because magnet status is real and huge, that removing that is not going to be a problem. But again, to, Jessica, I believe it was you that brought it forth, the title protection. What has occurred in these employer-based situations trying to obtain magnet status is they're using non-CNSs and giving them the title of a CNS. And that is, I believe, one of the contributing factors to your numbers going down, because they're not being hired and required because they're hiring a lesser prepared person that doesn't have this certification, filling the role that is really designated towards you guys. And so, again, I hear the fear. I know that you're worried about preceptorships. Again, in the preceptorships, there is not a require for national certification. So if you're already precepting and your academic institution will utilize you and you have the certification as a CNS, you will be able to continue in that role. It would have to change on the academic institution to require a national certification, right? It would have to change in your hospital bylaws to require the national certification. And we're looking at shortages. They're not going to shortage themselves out of their ability to continue to operate in the manner that they're currently operating. And so that's always something to consider. I love that you brought that forward and shared that with you. And Alina, if you're still on, you can unmute and continue to jump into the conversation. But remembering again that this is just a recommendation on drafting regulations. We have no language. It's going to come back to you guys in the fall. And if you guys see this language in the fall and you guys have collected data, then in the fall, you'll say, I have data that says this. Alina, if you wanted more CNSs on the call in the fall and you wanted to line it up with hundreds of CNSs, You could do that in the fall. That is actually when they're going to have language to opine on whether or not this is something that can move forward to our board. But this is just direction for this regulatory subcommittee to draft language that we can bring back for you guys to look at in this subcommittee. I mean, in this advisory committee. And if you guys in this advisory committee say no go in the fall, then it's a no go in the fall. It doesn't even make it to our board. So this is just a direction for the subcommittee to draft regulatory language to bring back to this committee in the fall to get more public participation and more public input.
Thank you. And then I just want to be very respectful. I see Vicky would like to make a comment. And Loretta, that was very clear. Thank you so much.
Thank you. And then I do want to be mindful. I know that we're after 3, we're set to end at 3. So I want to make sure that if you guys have to drop off, if we do lose quorum, then we do need to stop. But if you guys can stay on for maybe 10 minutes and we can wrap this up by 3:15, that would be appreciated.
Thank you for your comment. Vicky would like to make a comment. 1 second.
Hi, can everyone hear me?
Yes.
Oh, awesome. I thought my microphone was not working. Anyways, mine is more of a suggestion. I was only notified of this meeting just this morning, and I think if you guys want more of a public appearance is to maybe give a more of a notification in advance. I would like to continue on listening on these meetings in the fall. I am very for and pro reaching national certification. I currently am not a CNS, but that was one of the careers that I was looking into pursuing, but I do see the benefits of advancing the nursing profession. But if you guys can just give a little bit more notification in advance, I would really appreciate it. Thankfully, I had today off, so I was able to attend this meeting. That's it.
Yeah, no
Thank
problem.
you.
So just for clarification on that, Vicky, when we post an agenda to our board's website, whether that's 2 weeks in advance or 10 days, which is what our mandate is, that same email goes out. And so you should have, if you received an email this morning, you should have received that email 10 to 14 days ago as well. That is something that we put out on our listserv. If you're not signed up for the listserv, if you go to rn.ca.gov, on the right hand side under quick hits, it says join our email list. And on that email list, you click on that, it says subscribe to free email updates. You can enter your email address and you can ask for general notification, regulatory updates, or all, and you can subscribe and you will receive an email whenever we post anything. It goes out to a listserv, and so you have that and you're able to plan.
Oh,
the other
perfect.
thing is if you don't want to add us to your inbox, and some people don't, rn.ca.gov, again, our homepage, on that quick hits is also a link to meetings. And on that meetings, every one of our meeting dates are posted for the entire year of 2026. And you will see the agenda and materials that go there as well. So you can come to any of those meetings. They're all held virtually in a virtual manner that allows for virtual participation. Some of them are in person, but this one here is completely virtual. So please feel free to attend any and all of those meetings. Public participation is what we want. So appreciate
perfect.
that.
Thank you so much for the support.
Definitely. Thank you.
Mm-hmm.
Thank you for your comment. And Alina says, appreciate this committee. Committee Chair Lightcap, there are no other public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes. Okay, and moving on to a roll call vote for
Could you
the
please-
motion that
I'm sorry, just please repeat the motion. Thank you.
You're on mute, Carrie. Sorry.
Thank you. The motion is to add a national certification requirement to the CNS regs verbiage, just to be able to draft language as to what that would look like. and bring it back to this committee in the fall.
Okay. So roll call vote. Jessica Lightcap, yes. Elisa Brown,
Yes, I that language I can live with. Thank you.
Carrie Krogan,
Yes.
Elizabeth Scruff,
Yes.
okay, and Marilyn Bobbio is absent.
Now you're muted, Lori.
Goodness gracious, I'm doing this today. Sorry. Listen, Carrie, if you guys feel confident on your path forward, go ahead with it. And that's fantastic. If you want to involve Macaulay and I and or Reza at that and kind of look at how that alters it, we're happy to jump in at any point. Just reach out to Macaulay and we'll get that scheduled. So thank you.
We will.
Yes.
Okay, moving on to item 9.0, adjournment. The meeting is 3:09. Do I have a second for
You don't
adjournment?
even have to. You just say we're
Okay.
adjourned. We're done.
Adjourned.
We're
Thank you
adjourned.
guys for an extra 10
Thank
minutes of
you.
your time today. I appreciate it.